Good morning, everyone. My name is Stephanie Romano, and I'm the Education Coordinator with the Base Hospital Program. Welcome to another edition of SWORB webinar. Today we'll be talking about capnography. And this is actually a part 2 of a series of 2 so far. So we did do a part 1 capnography review a couple months ago, and the feedback was great, and it sounded like the majority of the attendees wanted to see round 2. A little bit more detail, referring to some case studies, so that's what we're doing today. If this is your first time joining us for a webinar, there's a couple things you need to know. So there's a control panel that you're probably seeing on your computer right now. In that control panel, you'll see a hand, and you'll see a chat box or a question box. So throughout the presentation, feel free to send any questions or comments through that chat or question box, and I'd be happy to answer those in the background. If you do ask a question that I think the entire group would benefit from hearing the answer, I will actually present the question to the presenters, and they will answer those questions live. So feel free to do that throughout the presentation. If you do have a question that you'd like to ask live, save that till the end of the presentation, and at that point you'll be able to click on the hand icon, and I can see that you've raised your hand, and then I can unmute you, and you can actually ask your question live at that time. So again, throughout the presentation, type your questions in through the question or chat box. If you'd like to ask live, save those till the end of the presentation. And so here are your presenters. We've got Christine Hardie, Prehospital Care Specialist with SWORB, and Matt Davis, Medical Director of Education here at SWORB as well. So take it away, guys.
Well, thank you very much, Steph. Good morning, everyone. Thanks for joining us for the second part of our capnography review. Again, as Steph said, we were asked by a couple of medics to expand on our last one, so that's what we're going to try to attempt to do today. So upon completion of our webinar today, we would like you to be able to describe the 4 phases of a normal capnography waveform. That's a review again from the first webinar. Discuss the pathological conditions that alter end-tidal CO2 readings. Describe the scope of capnography use in the pre-hospital setting, and relate those waveforms to simulated pre-hospital case studies. So for those of you who joined us in the first webinar, you may recognize this slide. We're going to review the basic waveform again because it's important to be able to fully understand and utilize end-tidal CO2 monitoring in the pre-hospital field. You should be able to recognize and fully understand the normal waveform. So as a quick review, notice that it's a reading of end-tidal carbon dioxide over time in seconds. So the first phase is the beginning portion of the waveform, and in this section there is no expired carbon dioxide. It basically consists of dead space gases, so the carbon dioxide is 0. The second phase is the beginning of the expiratory phase, when a patient begins breathing carbon dioxide out. It rapidly increases and then eventually hits a plateau phase. So we're going to stop again at this plateau phase and examine it. You'll notice that it has a slightly upward increasing phase, and basically this is because of alveolar concentration gradients. So as the bottom portion of the alveoli begin to expel carbon dioxide, that's why we get this upwardly increasing slope. The orange phase, or the orange circle phase, is the inspiration phase, so there's no carbon dioxide expelling out of the lungs at this time. The end-tidal phase, the reading that we're going to get on our monitor, is this phase here you'll see with the yellow star. Okay, so what's actually occurring in the body? Again, let's look at the normal capnogram. So the capnogram is a measurement of ventilation, perfusion, and metabolism. So in this phase, you'll see that the expired end-tidal CO2 is between 35 and 45, and that's our norm. The ventilation is adequate, again, because the amount of expired end-tidal carbon dioxide is between 35 and 45. The perfusion is adequate as well by monitoring this capnogram, because if there's enough blood perfusing to the lungs, then we should be expiring a normal amount of end-tidal carbon dioxide as we continue to ventilate normally. At the same time, we can tell that metabolism is normal, meaning the cells at the cellular level, carbon dioxide is being produced adequately, and that because in a normally ventilating and perfused person, our end-tidal CO2 is between 35 and 45 millimeters of mercury.
So this is where capnography gets maybe a little bit messy at times. So in a healthy individual, it's a pretty exact kind of science because you have normal ventilation, perfusion, and metabolism. In some disease processes, you have an issue with just one of those problems, and that can have an effect on the capnography tracing. However, as we know, with a lot of our patients, they have multiple issues going on. So, perfusion issues with ventilation issues, or they may have metabolic issues along with their ventilation problems. So that's when the capnogram gets a little bit complicated because you have multiple forces acting upon it. So, in a pure disease state, it's a great tool. When there's multiple issues, it starts getting a little bit more complicated in order to interpret.
Good. So before we get into our case studies, let's take a really good look at the differences between the measure of ventilation, perfusion, and metabolism. So looking at this waveform in front of us here, you can see the one on the top is a patient who is hyperventilating. And as a patient is breathing faster, they're breathing out more carbon dioxide, so their end-tidal reading will be lower. In a patient who breathes very, very quickly, they can decrease their end-tidal carbon dioxide level significantly. In the lower capnogram, you can see this is a patient who's breathing much slower. So the end-tidal carbon dioxide level is going to be increasing in that case.
And with the hyperventilation, you can think of the old paper bag tricks. Why do the old you see in the movies or the old school kind of things where they give you the paper bag to breathe in when someone's having an anxiety attack? Well, what's happening there is you're breathing off all your CO2. You're hyperventilating, so your capnogram reading is going to be higher. And the thought with the hyperventilation is as you blow off that CO2, that's the driving force behind breathing, so you're going to start breathing more of that CO2 back in as opposed to just purely oxygen and less CO2, and that's what is supposedly helps slow down some of the breathing.
Good. So where does this come into play in the field? Looking at these types of waveforms can be useful if you're trying to coach your patient, but in patients such as overdoses or patients who are receiving narcotics for treatment or even patients being sedated, say, for pacing, this is a good representation of how they're ventilating versus how they're oxygenating at according to your SpO2 level. Also, if you were to watch the capnogram during resuscitation of a patient who is VSA, you could examine how well they're being ventilated, or if they're being ventilated too quickly, that we know is problematic. And when we're resuscitating people, sometimes overventilation is a problem. So monitoring those types of things is how this becomes useful at this level.
And the benefit of end-tidal CO2 measurement is, unlike pulse oximetry, when you have a lot of muscle artifact, you get a lot of, so someone who's seizing, for instance, you'll have a difficult time picking up an O2 sat, or as well someone who's hyperperfusing, you won't pick up an O2 sat. However, with the capnogram, it's not based on, it won't have any interference from muscle artifacts, so from seizing, from movement, or as well as hypoperfusion. So those factors that kind of are the downside to pulse oximetry don't occur with capnography.
Good. Okay, so moving on to looking at end-tidal as a measurement of perfusion. We know that in a normally breathing patient, if there's enough blood flow, we will have an end-tidal CO2 reading of between 35 and 45. However, if something were to change and we had a decreased amount of perfusion to the lungs, such as in the case of a severe trauma patient, then we would start seeing a decreasing trend in the end-tidal CO2 readings. And this is basically because there is just no blood that is getting to the lungs, and then carbon dioxide cannot be expelled. Anything else in there? So what's the take-home message from this portion of the EndTidal CO2 reading? Basically, if you're looking at a sick patient, so a severe trauma patient, and you're seeing a low EndTidal CO2, its value for us is predictive in sometimes survival, or even maybe in recognizing an early sign of shock.
So another tool that you have at your disposal to help gauge the severity of illness within this patient population. I wouldn't act on it significantly just alone, but it's again another piece of the puzzle.
Exactly. Some studies have shown that patients, especially severe trauma patients with lower EndTidal CO2 levels, die more often than patients who don't. Again, we would never start changing the way we're ventilating a patient based on this, but as a predictive tool, it's another piece of the puzzle. So looking at, again, the measure of metabolism. So what are we looking at in this circumstance? The EndTidal CO2 level can be a direct measurement of how the cells are metabolizing and how well they're expelling carbon dioxide. So basically looking at changes in the production of carbon dioxide at the cellular level after metabolism has occurred. So if you think of when metabolism could be impaired, is possibly a diabetic patient who is not utilizing glucose well or at all, and we're not producing carbon dioxide.
So in these instances, the carbon dioxide production, and with for instance the DKA, they're going to try to blow off all their CO2 because that's considered an acid in order to help decrease the acidosis within the bloodstream. So these people will have a lower EndTidal CO2 reading because they've gotten rid of all that extra CO2 in order to compensate for their metabolic acidosis.
Okay, I think I said that backwards. All right, so again, we're going to start some case studies, and this kind of actually is just going to bring us right to the end of our webinar. So please make sure as we're going along that you type in or you activate your mic, and we'll make sure that we're answering any of your questions. So the first case we're going to discuss is a call for shortness of breath. This is to a residence for a 45-year-old female. On arrival, the female patient's in the tripod position in the living room. She's sitting on the sofa. The incident history is that she was cleaning her house and inhaled some cleaner over the next hour or so. She began getting short of breath. She opened her windows, but complained that her breathing remains difficult and she's unable to feel better.
So she's inhaling the fumes, not the cleaner itself. She wasn't doing lines of bleach or anything like that.
And the fumes from the cleaner. So this female has a history of asthma and COPD. You can see her medications there, and her heart rate on your monitor is 110, sinus blood pressure is 130 on 85, respiratory rate is 26. SpO2 is 97, and because we're utilizing EndTidal more in the field, you've got an EndTidal monitor on, and it's reading 52. In the particular capnogram you see in front of you, you can see we put that one on purpose, that it's an increasing trend slightly from about just below 50, that eventually it's rising over time is the point we're trying to get across. Okay, so we would go through our normal treatment with this patient, oxygen, cardiac monitor, consider salbutamol. But what's interesting to note here is that this is a very specific capnogram reading, and it's in fact has a kind of a characteristic shark fin look to it. So very typical of patients who are experiencing bronchoconstriction, asthmatics, patients with COPD. This is because there's a mixing of the dead space air and alveolar air, and over time it's basically taking longer and expelling differently than in a normal patient. So as we start treating this patient, what the goal is obviously to start lower the EndTidal CO2 level, relieve the bronchoconstriction with the use of bronchodilators, and alleviate this patient's shortness of breath.
So with this capnogram, you can see that the plateau phase is probably a bit longer than you expect, and that's representing expiration. And with bronchoconstriction, you have that long expiratory phase, which is represented here on this capnogram.
Again, we can't just use this tool when treating patients in the field, but interestingly enough, the asthmatic will present to you possibly hyperventilating on arrival at first, which, if you recall, will cause lower end-tidal CO2 levels. So as we progress through treatment with this patient and we begin to slow down their breathing and we begin to treat them with the bronchoconstriction, we'll definitely see changes in this waveform, hopefully to the point where it's back to the original waveform that appears normal. Another thing that is interesting is that if you have this capnogram visual on your monitor, this is something that can't be, it's not an error. So this characteristic shark fin is very typical of bronchoconstriction. You're not likely going to see it if there isn't something going on with the breathing. Our next call is code 3 to a nursing home for an 87-year-old with increasing or increased confusion. She appears to be alert, but not responding appropriately to words, or he is lying on his left side in the bed, and he definitely appears confused. So he has a history of dementia, recent urinary tract infection, hypertension, atrial fibrillation. His medications are there in front of you. Heart rate ranges between 120 and 140. Blood pressure is 100 and 70. Respiratory rate's 28, sitting at 99%. Fever, has a temperature of 40 and has an end-tidal reading of 40 millimeters of mercury. Another good thing about the end-tidal CO2 monitoring in the field is that when you're attaching it to your patients, you're going to get very accurate respiratory rates as well, which we should be monitoring in the field for them decreasing over time. So Matt, I may let you discuss this one.
So just looking at this kind of patient presentation, so we've got a tachycardic patient, borderline blood pressure there. For someone who has hypertension, that's probably a representation of hypotension in them, and a temperature of 40 degrees. So someone who's got increased confusion with this kind of set of vitals, right off the bat I'm starting to think, is this patient septic? So their end-tidal CO2 reading of 40, we know kind of the normal range is 35 to 45. So what does this mean? And again, this is an issue with multiple factors playing here, where it's not just a clean-cut one issue going on with this patient. So you've got some hypoperfusion occurring most likely, as well as probably a metabolic acidosis secondary to the sepsis. So when you're septic, you start producing a lot of lactate within the cells, which get released into the blood, and you become acidotic. So in these patients, now you've got to, multiple things playing here. So, if it was just one pure thing, we'd expect, they're going to blow off all that CO2 and lower that end-tidal CO2. But at the same point, they're hypoperfusing, so they're producing a lot more carbon dioxide. So that's kind of why you end up with that CO2 reading, which appears to be normal.
So again, how has this become relevant in the field to us? Well, many studies have shown, and I'm sure some of you have heard, that there's a correlation between recognizing septic people very quickly in the field and in emerge, and getting treatment with antibiotics as soon as possible. The sooner it occurs, the lower the death rate. So for us, if we're seeing this patient, which we were hoping your differential diagnosis was sepsis, recognizing the fact that we have low end-tidal CO2 level, we have poor perfusion, and we're going to have a buildup of the, basically we're going to have metabolic acidosis occurring. We can pre-alert the hospital staff, possible diagnosis of sepsis if you're going down that road, and then get the patients into treatment quicker.
So you may find sometimes with these septic patients that you have a lower end-tidal CO2 than what you would expect, so a lower than normal level. That's because, again, the lactic acidosis is building up in the bloodstream, so the patient's becoming more acidotic, and the body compensates by trying to get rid of more carbon dioxide, which is considered an acid, in order to compensate for that. So over time, these patients begin to have a lower and lower end-tidal CO2 as that body tries to get rid of more and more of it, so there's less circulating and less being present at the capnogram reading. Again, multiple factors playing when we think about ventilation, perfusion, and metabolism. So again, as we said, this is just a piece of the puzzle because unfortunately it's not the cleanest tool for saying CO2 is 40, or sorry, the CO2 is low, therefore it is sepsis. There's multiple things at play here. So, you know, it may be within the normal range despite being a septic patient. It may be on the lower side despite being a septic patient. So you'll hear this throughout the presentation. Again, just using this as a tool, one piece of the puzzle.
Good. I was hoping we'd have some questions coming in by now. Not yet. Okay, we're dispatched code 3 to a group home residence for a patient who's generally unwell. On arrival, you're met at the door by a healthcare aide who states she came to the patient's residence today, found him unresponsive. You note the patient's paraplegic and approximately 50 years old. So again, the patient suffers from paralysis from a car accident 3 years ago and is an insulin-dependent diabetic. The patient does have a decreased LOA, so you do take his blood sugar and it reads high. So he's on some insulin, heart rate is 98, should be a little bit tackier, blood pressure 94 on 75. You've hooked up your EndTidal CO2 monitor, so you have a reading of 35, a little bit on the low side, respiratory rate of 30, and an SpO2 of 98. So looking at this particular patient, on our glucometer levels, we have a reading of high. So that means generally with most glucometers that it's above 28 for the most part. What happens when the body starts not utilizing insulin properly or not receiving enough insulin is the body begins to burn and create lactic acid. So this patient's basically a DKA patient is what we were trying to get across. And as you recall from what Matt said earlier, as a patient is trying to remove acid from their body, they're going to start to increase the respiratory rate and blow off carbon dioxide. So that's exactly what this patient is doing. You can see the fast respiratory rate, and in fact it's most DKA patients end up in Kussmaul's respirations, and that's the exact reason why. So we have a falling EndTidal CO2 level, and again, just another piece to the bigger puzzle. We have a poll question coming up here shortly. Okay. All right, case 4 is for call for chest pain. Called code 4 to a clothing store for a 36-year-old female complaining of chest pain. On arrival, you find a female patient sitting on a chair, moderate distress, who appears very frightened. She reports a sudden onset of stabbing chest pain this morning before coming into work and feels like she cannot breathe. So her history is 6 weeks postpartum. She does not take any medication, and her vital signs appear to be within normal limits, other than her SATs are quite low, 91%, and if you notice, her EndTidal CO2 level is quite low as well, hovering around 30 or below. So when looking at this patient, she's describing her chest pain as sudden onset, acute, pinpoint to the first side, and if we were to look at the big picture and differential diagnosis, are we looking at cardiac ischemia or what type of pain is this? The history of 6 weeks postpartum, sudden onset, pinpoint on the left-hand side, the female's age. We were hoping that you were leaning towards pulmonary embolism in this case, especially with the low SpO2 reading. So where this comes into play with the EndTidal CO2 is that there isn't enough blood being delivered to the lungs, so we're seeing a lowering trend of the EndTidal CO2 reading. Again, a piece of the picture, not necessarily going to diagnose a pulmonary embolism based on this, but we have another piece to the picture that possibly because the lungs aren't being perfused adequately, that there's a higher chance this could possibly be a pulmonary embolism.
And this would not be just a smaller type of pulmonary embolism. Something like this would be a massive pulmonary embolism to cause the EndTidal CO2 to read or to drop. So we've got a 36-year-old with sudden onset of chest pain who's 6 weeks postpartum. Postpartum, they're more risk for developing pulmonary embolism, who is hypoxic. That would be, again, the first thing on my differential, especially with such a low end-tidal CO2 read. Again, this is an issue of perfusion. So you have that big clot sitting within the pulmonary vasculature. Blood is unable to get to the lungs in order to get rid of the carbon dioxide and pick up oxygen. Again, not just a small little subsegmental PE because you have enough lung tissue and perfusion throughout the rest of the lungs. I wouldn't expect this kind of end-tidal CO2 reading. But someone who has a very large PE who is not perfusing the lungs very well at all, this is the kind of capnogram I would expect to see. So the majority of your patients with PE aren't going to present like this, but the ones with severe PE may. And again, here's a young, healthy woman who's got no other issues affecting her lungs. So it's a very clean kind of case. And as you know, the majority of our patients have multiple issues going on, so may not present as this clean. So as Christine said, just another small piece of the puzzle to add as a piece of evidence in trying to figure out what's going on with your patient.
Good. Okay, case 5. Again, another patient short of breath. This is a call to residence for an 86-year-old male. He's alert-oriented, sitting up, is in severe respiratory distress, using accessory muscles and speaking in 1 to 2 word sentences. Crackles are audible as you enter the scene. So he has a past medical history of hypertension, but reports he doesn't take any medications. Heart rate is quite high, 140, blood pressure 201 on 116. You put the end-tidal CO2 monitor on and you realize he has a respiratory rate of 30 and his end-tidal is also 30. So looking at this patient, we're going to treat him as we would any other patient, oxygen cardiac monitor. When you auscultate, he's full of crackles, so he has some pitting edema. We're trying to get you to go down the road of pulmonary edema and treat your patient accordingly. So we would start off with some nitro if applicable and CPAP if applicable. But again, want to discuss how this end-tidal CO2 fits in here. Why would this possibly be low? What's occurring in the body? This is another example of where we would have multiple things going on at the same time, altering the end-tidal CO2.
So you'd have issues both with perfusion and ventilation in this case. So with CHF, what's the cause of a CHF? Most likely just kind of a heart that no longer pumps as well as it should. Therefore, you're going to have a decreased cardiac output, which would cause you to have less blood perfusing to the lungs, which the blood delivers the CO2 to the lungs to be expelled. So in this case, that would be one factor causing for the lower CO2 reading. And also you now have a lot of fluid around the alveoli, within the alveoli, causing decreased ventilation. So that transfer of carbon dioxide to the alveoli. And that's another reason as to why you may have a low end-tidal CO2 reading. So here's a case where you've got multiple reasons, perfusion and ventilation, that's causing you to have a lower end-tidal CO2.
So not that this would necessarily lead us in a direction for treatment for a patient, but what it would do is monitor whether what we are treating the patient with or how we're currently treating the patient is helping them as well. Because the trend over time should be that we're decreasing the patient's respiratory rate and we're increasing the amount of alveoli that are able to oxygenate and produce carbon dioxide, increasing our end-tidal, hopefully, between 35 and 45. So we had a question come in, and the question is, why monitor end-tidal CO2 levels in trauma patients?
So Christine, I think you answered that quite nicely earlier on there as to what piece of the puzzle that can add for the trauma patient.
Oh, okay, I'll repeat that. So in most busy calls, end-tidal CO2 monitoring can come into play because when an end-tidal CO2 level is low or very low, it indicates a very sick patient. And it means that they're not, well, in the trauma patient specifically, possibly not perfusing adequately, and then therefore not ventilating adequately, even though they may have a high SpO2. It doesn't necessarily mean that they're ventilating adequately. So it's predictive of, again, it's predictive of sick patients, maybe increasing our levels of concern, or just another piece of the puzzle.
So yeah, I mean, many factors where you could have lower end-tidal CO2 readings in the trauma patient. Another one would be hemorrhagic shock, so you just don't have enough blood to get to the lungs to deliver that carbon dioxide. It could be another marker of a lactic acidosis. So lactic acidosis in the trauma patient is representation of hypoperfusion. So when you become more acidotic, you want to get rid of that extra any CO2 you have, so you try to pull off that CO2, causing a lower end-tidal CO2 reading because you've increased your respiratory rate. So again, multiple issues as to why you could have these low readings. So it's just another small piece of the puzzle as a potentially very sick trauma patient.
Also, the ability to have an ongoing respiratory rate is helpful as to, if you're not able to utilize the actual capnogram and the end-tidal CO2 level, you definitely have a respiratory rate. And over time, as you use it, you'll be able to see, you can recognize whether your patient's ventilating adequately or not, breathing adequately or not.
And there may be multiple factors why they can't increase the respiratory rate. So just a small piece of the puzzle. They may have, a head injury causing them to have respiratory depression in addition to all their other traumas. So again, this is where we go back to saying, unfortunately, capnography is not the purest, cleanest tool for measuring something independently. There's so many factors which play into it that will cause your end-tidal CO2 to be higher than you would expect, or lower than you expect, or within the normal range when you expect it to be higher or lower. So again, just a piece of the puzzle, another tool you can use for your clinical judgment.
Great.
Christine, I think we have a poll question if you want to go forward with that.
Okay.
So I'm going to increase the interactivity here. So I'm going to launch a poll for everyone who's watching. So the poll question is, what condition results in a shark fin capnogram? Your options are A, severe trauma, B, pulmonary embolism, C, asthma, or D, CHF. I'll give you guys just a few seconds to answer that, and then I'll close it and release the results. All right, so we're sitting at 75% of people have voted, and I've got 80% of people saying it's asthma, and 6% severe trauma, and 6% pulmonary embolism. So the majority are answering C, asthma.
So asthma is the correct answer. Again, the shark fin pattern is representative of bronchoconstriction. You're having a long expiratory phase, so you get that long upslope with a sudden increase of the end-tidal CO2 towards the end of that plateau, giving it that shark fin-like appearance.
And this is one of the best applications for use for us in the field, is treating someone with bronchodilators and getting having a respiratory rate and then seeing changes over time, I think.
So yeah, definitely with potentially Ventolin use, Salbutamol use in these patients, as you start opening them up, you'll start seeing that shark fin become less looking like a shark fin and going towards the more normal type of tracing. So showing that your treatments may have an effect, or it may not. It may be a representation like, listen, we're using all this Salbutamol here and we're not getting any improvement. Again, just a marker, because I think clinically you're also going to notice that despite your Ventolin treatments, the patient's not getting better. They're telling you, no, I'm still having a hard time breathing. They still may be slightly hypoxic. They may be still super wheezy. So again, just another small piece of the puzzle that you have to use as a part of seeing how treatments work in this case.
Okay. Let's look at end-tidal CO2 monitoring in the intubated patient. This is the gold standard for tube confirmation. So definitely end-tidal CO2 monitoring needs to occur if there's a patient who's been intubated. It's 100% specific for esophageal intubations. So as a tool in the field for those patients, again, it's the gold standard. However, another way to utilize it is if we have a patient who we have a prolonged extrication or we have a noisy environment and we constantly want to reassess the placement of the tube, then that's something we could do by monitoring and observing the end-tidal CO2 waveform. That doesn't mean that we don't re-auscultate the chest frequently. However, it can be used as a quick tool to see, well, something's going wrong here because the end-tidal CO2 is low or zero. It will change much quicker than your SpO2 levels, so you realize you'll have to stop and check the patient's airway, reconfirm your tube.
So another question here has come in asking, or stating that sometimes waveforms with end-tidal CO2 reading is poor, and would this indicate that the value is inaccurate? And I guess it all depends what is meant by poor. So again, if you're looking at your end-tidal CO2 reading and your poor waveform is just a low end-tidal CO2 reading, and you're looking at it and it's correlating with their respiratory rate, then it most likely is an accurate reading given the fact that they're just not producing a lot of end-tidal CO2. So again, looking at it in context with your patient. Potentially your poor waveform may be an equipment issue. So you're getting a poor reading and this patient has no wheezes, they're talking to you normally, they've got some oxygen on, and it's just a flat line. Well, that may be more of an equipment issue. So again, you've got to take the waveform in clinical context as to what is going on. The thing about end-tidal CO2 reading, unlike pulse oximetry, is it should not be affected by movement. So, the patient is agitated, moving about, it's not going to be affected by that muscle movement. In seizures, it's not going to be affected by the muscle movement. It's purely just feeling the breath being passed by and making a reading of that CO2 which is within that breath. So again, hypoperfusion, it's going to be a lower end-tidal CO2 reading likely, but should still be correlating with the patient's respiratory rate.
Yeah, that's a good question, and I think in the field what we do typically is we see a low SpO2 reading and we immediately look for the waveform to see if it's an adequate waveform. If it's not, then we're thinking, oh, maybe the patient's the monitor's off the patient's finger, or maybe their hands are cold, and that's why we don't have a great waveform. Thus, we don't count on the number we're seeing in front of us. Versus with end-tidal CO2, Matt said, if you don't have a good reading, then you need to look at your patient. So if in a normally breathing patient that you've got a respiratory rate of 6 but they're up talking to you, then maybe the nasal cannula type monitor has slipped from their nose. Troubleshoot from the patient back to the monitor, and then you'd be able to recognize. So in that way it's just a little bit different than the SpO2 waveform or the way we utilize the SpO2 waveform. Did you have is there another question? Okay. Good. Keep the questions coming. Okay, as we mentioned in the other webinar as well, is we can utilize end-tidal CO2, and this for patients who are VSA. So this is becoming more and more common. Different ways we can do that. So the end-tidal CO2 monitor can be put on patients who have a King LT inserted or are intubated, but we can also use end-tidal CO2 levels on just a patient that we're ventilating without an intermediate or advanced airway. So we can do that in two ways. Some studies have shown you can use the nasal cannula type scooper end-tidal monitor, or you can connect the end-tidal sensor between your BVM and your bag valve mask. Why would we do this? Again, absolutely used for confirming an endotracheal tube and monitoring end-tidal with the use of the King LT. But on the other hand, recognizing rescuer fatigue is one important role. So as we're performing CPR during a VSA scenario, for example, we should have sustained, or should have basically a sustained end-tidal CO2 level. If we started seeing those start to drop, then we would question why. What's going on? Do we have a situation where we've got rescuer fatigue and the perfusion isn't as adequate as it should be? Do you have anything to add to that? So that would, again, would be troubleshooting. Why is this low? What are we doing? Have we been switching out our rescuers? And we know that how important good chest compressions and ongoing CPR are. The other thing that we could use EndTidal CO2 for is recognition of a ROSC in the field. So if you were performing a prolonged resuscitation or even a short resuscitation and you have a sudden jump in your EndTidal CO2 levels that sustains itself relatively, then you might want to consider that you have a spike in cardiac output, which could indicate a ROSC. This, however, is not going to change how you run your regular cardiac arrest. What it might help you with is understanding that when you stop to analyze the next rhythm, that it could possibly be a perfusing rhythm. So stop, analyze your rhythm while, and then check pulses adequately and make sure you're checking pulses for a long enough period of time, and you have the evidence in front of you that could possibly say that you have a ROSC going on. So maybe taking that extra second.
Yeah, I think that's a great use for it there. You've seen that bottom schematic B there. You have that, you know, underlying low end-tidal CO2 reading and suddenly that jump there. So the next pulse check, you know, seeing that, I'm going to think, well, you know what, I am going to really search for that pulse and see, because that's a good indicator that they potentially have return of spontaneous circulation. So, you know, get your partner, you know, 2 hands on there to check for that pulse just to confirm that you do have ROSC. So something to be aware of when you're running those cardiac arrests.
Mm-hmm. Steph, did we have another poll question at this time?
Yeah, we sure do. So I've just launched it. So the question is, a VSA patient has a sudden spike in end-tidal CO2. What intervention may have caused this? So your options are A, epinephrine, B, sodium bicarb, C, amiodarone, or D, a fluid bolus.
No, we didn't mention.
That's a tough question.
Yes. Make sure everybody's still awake.
Exactly. It's all about interaction. So I'll give you guys a couple more seconds to answer that. Looks like right now we're sitting about 50-50 epi and sodium bicarb. So let's close that. Share. So yeah, we're sitting 45% epi, 45% sodium bicarb, and 9% fluid bolus.
Okay, interesting. Do you want to speak to that, Matt?
So when you're giving sodium bicarb in an arrest situation, so for instance you may recognize the need for sodium bicarb, patch in for that order. When you do give sodium bicarb, at the end of the day, sodium bicarb breaks down to hydrogen ion and CO2. And so again, that CO2 that it breaks down to may cause a temporary increase in the end-tidal CO2. You may not see it, but you may see it. And again, it's a very, very short-lived jump in that end-tidal CO2 reading. You know, I wouldn't pay too much attention to that in your cardiac arrest. Again, it's not going to make it jump from like 10 to all of a sudden, you know, 40 as you would expect with the ROSC patient, but may take it, you know, from 10 to 14 suddenly, and that's just the metabolism of the bicarb down to its basic forms down to the hydrogen ion and carbon dioxide. Another question came in here asking about how the end-tidal CO2 reading would change if the patient is intubated in the right mainstem bronchus versus proper placement. Unfortunately, this is not a tool that you can use to help determine placement, because there's so many different things going on with that patient in front of you. So, you know, in a relatively healthy person who, for whatever reason, gets intubated, has got healthy lungs, and you do the right mainstem bronchus or bronchial intubation, you may see no changes in that end-tidal CO2 versus someone who's got a poor reserve for whatever reason, gets intubated in the right mainstem bronchus. You may see a decrease in that end-tidal CO2 because of decreased perfusion, or sorry, decreased ventilation to that right lung, less CO2 being delivered, and that left, sorry, the more left lung is not being ventilated, therefore you're getting rid of less CO2 in that lung, and the right lung just can't compensate it for whatever reason. So I would not use end-tidal CO2 reading to determine if or if not that the patient has a right mainstem bronchus. I would rely on your other clinical indicators. You know, what's the tube depth? What do the breath sounds sound like? are the two biggest ones to look at there. And of course, if they're desatting in front of you because that left lung is needed for their oxygenation, that would be another clue. But I wouldn't rely on end-tidal CO2 to determine if it is a right main stem bronchus.
Good.
So summary to that answer is it depends.
Another tool in the toolbox, looking at your SpO2 level, if it's decreasing, auscultation, and you can utilize your end-tidal CO2 level. Good. Keep bringing your questions in. Steph, did we have one more poll question that was originally, I think we missed from the beginning of the webinar?
Yeah, we do have one left. Did you want to do it now?
Yes, please.
Sure. All right, so I've just launched it. The last question is, what will alter the amount of CO2 expelled by the respiratory system? And so answers are A, pulmonary embolism, B, bronchoconstriction, D, C, sepsis, D, all of the above, or E, not sure. There's about half of you that have voted, so we'll give you a couple more seconds here. All right, so just close that out. 100% of everyone who's watched has said 100% all of the above.
Well, that's excellent. We were hoping no one wrote what they're not sure. That's very good. Okay, so I hope what we've done is further take end-tidal CO2 levels to the point that you've asked for it. However, we don't want to go too far in depth saying that we have absolute things that end-tidal CO2 monitoring can do, because that's unfortunately just not the case. It's another tool in your toolbox to help with differential diagnosis, problem solving, reporting early to the emerge on sick patients, basically. Some take-home messages at the end of the day with end-tidal monitoring is we'll start using it. That's a good start. See how it does come into play if it does help your clinical practice, and then go from there. It's absolutely the gold standard for endotracheal tube confirmation and reconfirmation, and just monitoring it over time. Low end-tidal levels in seriously ill patients or injured patients is a bad thing. It's not good. So having that in front of you as well could or could not be helpful.
And also a very high end-tidal CO2 reading in a seriously ill or injured patient is also not good. So using the both extremes, that's telling you these are very sick patients.
And yeah. So do we have any other questions?
I think another thing to remember, again, as we said throughout this presentation, is end-tidal CO2 readings are dependent on ventilation, perfusion, and metabolism. So there's a lot of factors at play. So it's not the cleanest tool for diagnosing something. It's just a small piece of the puzzle to use.
So we don't have any other questions right now, and I don't see anyone who has their hand up. So if you do have a question that you'd like to ask live, go ahead and raise your hand right now by clicking on the hand icon. If you don't have any other questions, then I guess we can just wrap up. So a huge thank you to Christine and Matt for another great webinar. I think this is something that the medics had asked for, and we've had a 6 to 8 week turnaround to actually present the webinar. So great job on that, guys. For the audience, we do have another webinar coming up in April on 12 weeks. And the questions, 12-week issues that are sort of keeping you up at night. That's the title of it. So if you do have any 12-week questions, do send them to me. Send them in to us, and we'll actually discuss the answers during the webinar. So definitely something to keep in mind if you're looking for extra points or if you're interested in a 12-week webinar coming up in April again. So I don't see any hands up. So again, thanks to Matt and Christine and everyone else. Have a great day.